Hey guys, welcome back to the channel. Today we're going to talk about something which needs to have light cast on it. And I am very, very happy to have Dr. Sapna, who is a board-certified psychiatrist here. And what we're talking about in a series of sort of conversations is about what we need to understand with psychiatric issues and psychological issues. Because in India, I would say that it's been a very, very hard journey for us. And we've discounted a lot of these things. I think after the pandemic, you and I have talked about the issues people have faced. But in specific, today what we'll talk about is eating disorders. Now, some of you can say, well, eating disorder, come on, people all have to eat, it's no big deal. But in truth, we've known about them for centuries. And it's only recently that they've been identified. And, I'll tell you an even more poignant story. A dear friend of mine, daughter had anorexia nervosa. And we had always been taught that it carries a 50% mortality rate over a lifetime if not treated.
Yeah. It's one of the rare conditions in mental health which can be lethal. So it needs to be addressed.
And so, we in our culture talk about this and we sort of have a conversation on the fact that thoda mota zala hai, thoda chota zala hai. It's sort of a cultural thing when mom or grandma or someone sees you. But that sort of stuff coupled with Instagram, with all the other things that are going on in social media are really bringing it to head. So I'm really excited to talk about this stuff with you and kind of to educate our audience because I think it's badly needed. And so thank you so much.
Thank you for having me.
If you want to see more episodes like this, hit the like button and the subscribe button and always share this with your friends. Hey guys, Dr. Nene here. I practice as a cardiothoracic, vascular, and general surgeon, and I'm now a health tech innovator who wants to improve lifespans and lifestyles. So stay healthy, stay curious, and keep watching. So let's get on with it. Tell us a little bit about your experience with this. You told me you were actually in an inpatient unit in London where you trained, and also in India, you had a full-time practice, and part of it was that. What's been your experience in India with eating disorders?
I think there's a huge lack of awareness about eating disorders. People don't take it too seriously. It's like, she's not eating, she's lost a bit of weight, but no one is thinking that it's a huge issue or it might be a condition that needs to be treated. And that's been, I think, for example, when I was training, it was supposed to be a culture-bound syndrome. It was not supposed to be something that is affecting, Asian cultures. It was something that is for the Western cultures, for the, the rich. It was not supposed to be universal. But now in my practice, I'm seeing a lot of younger people coming with eating issues, self-harm, sexual, orientation, confusion, and drugs and alcohol. So it's one of the top 4 out there for the younger people.
That's very interesting. And I would say what I'm seeing also in the last 20 or 30 years as these camera phones and all that come, the size 0, how everyone in the West and even here through the film industry and other things, which I'm intimately aware of, how they put such a high sort of value on how you look. And, I've always said it on the channel that you're all beautiful and that it needs to be the intrinsic happiness that motivates you. But we often look at
But the kids don't believe it.
No,
the kids don't believe it, and I think you've touched upon a very important topic of social media because the fat shaming, the body shaming just doesn't leave you. So I think that's the social media has its boons, but the banes are there as well.
So let me ask you this, that when does it become an eating disorder? How do you define that? Because, you might say, well, someone's getting skinny. And, in preparing for this talk, I read through all this and it was fascinating because there's kind of shades of gray where you avoid stuff, you hide stuff. Then there's stuff which is obvious obsessive compulsive behavior. So at what point, so I remember from my schooling, And I went actually to WashU, which defined the Diagnostic and Statistical Manual, which standardized the diagnosis of these conditions. So when you think about it, you get a patient referred to you and the parents say that the person is just not gaining weight. Now, in India, that can be many things. It can be malnutrition. 270 million people don't get enough to eat. And so you're wondering, well, how is it that you can have an eating disorder? But eating disorders could be, on either side. What do they mean to you as a psychiatrist when you think about it and when someone comes to you? How do you define that?
So for me, the main characteristic is the unhealthy relationship with food. So, when you're not happy, when you're feeling a sense of guilt and shame associated with food, that is the underlying characteristic. So it's not, not being able to eat or, not gaining weight. It's a fear of gaining weight. It's the overcompensatory behavior. So someone trying to avoid certain kinds of food, losing weight, and using compensatory mechanisms where they're not enjoying what they're eating. So a lot of times there are various kinds of eating disorders, if you know that very well. Yeah. So some of the common ones are binge eating,
okay,
bulimia.
So let's talk about binge eating.
Yeah.
What is that?
So binge eating, a lot of people, I think in lay terms we say, I had a binge, but that's not what scientifically a binge
So we
means.
talk about these, Sunday cheat days.
Yes.
Is that a binge eating?
That's not a binge eating. I'm enjoying what I'm eating on Sunday.
Okay, so I am too, thank God.
Yes.
But when does it become pathologic, if you will?
So pathological binge eating is when you're stuffing yourself with food and actually not tasting it. It's, eating a large amount of food in a short period of time, which is driven most probably by, emotional distress.
And what is the mechanism and the pathophysiology of that? You eat because it makes you happy? Like they have a term called nervous eaters, right? I've had various family members, friends, who when they get stressed, or like I had a lot of roommates in college, when they were stressed out for exams, they would eat and they would gain a huge amount of weight. Yeah. And you would just say, well, why are you guys doing that? And that was their way. And we also had a joke about it post-call, when you were up for 30 hours or whatever, that having a high carbohydrate, high fat meal would actually, theoretically give you all kinds of hormone support because the fat gets converted to estrogen and whatnot, and it makes you feel better.
Yeah.
And maybe, the dopamine and the serotonin and all the other things are firing. But is there science behind this as to why you do it?
So it's more emotional than scientific in terms of the binge. Yes, it makes you feel better. But in a binge eating, it's mostly when your life is out of control. So, following a breakup, following death, following a grief, where you're feeling very, very overwhelmed and your whole life is getting out of control. This is the only thing you can control. So, you're just eating and eating. And then immediately followed by a lot of shame and guilt.
For eating so much?
Yes.
And does that come after you gain the weight, or is that just after you eat?
You feel ashamed of losing control. You feel ashamed of losing control and eating so much, of giving in.
Okay,
Yeah.
And so that's binge eating.
That's binge eating.
All right. What is the next one you encounter?
So bulimia nervosa, so that is binge eating followed by compensatory mechanisms, by, over-exercising, purging, vomiting, using of laxatives, diet pills, diuretics, and a lot of distress.
So if you see someone, and I've seen it, where they overeat because they're emotionally unstable, something has happened, and then they feel guilty about it, and they'll go vomit. They'll make themselves vomit, which is incredibly bad for your esophagus.
Yes.
As a general surgeon, I'll tell you that. Or they take laxatives, or they think, oh, I can go work it off.
Yes.
And they go and exercise themselves, sometimes to death.
Yes.
Right? So that's the bulimia nervosa
Yes.
that they call.
Yeah.
Right? So then what is the next? Is it a spectrum? You start from one part and move to the next?
No, they're all a bit
They're all
different.
separate.
They're all
Okay.
a bit different.
So you can have one without the other?
Yes, absolutely.
Okay.
Absolutely. And then is the anorexia nervosa. I think that is the most, commonly heard about in cultures. It is where you're at an unhealthy low weight. So you're losing weight and there's body image issues. So you're refusing to accept that you're at a low weight. Everybody is telling you you've lost weight, but when you stand in the front of the mirror, you still feel you're fat.
So it's really a body image issue.
Yes.
And what I've heard is that this and obsessive compulsive disease kind of go hand in hand.
Yes. So a lot of times it starts with simple dieting and then, walking a certain number of steps or doing exercises, and you never know when it crosses the boundary to where it's pathological.
Okay. And so what of those three that we've described, and there's a few others.
There are a few others.
With anorexia, I know I shouldn't say interesting, but it's tragic almost, that they hide stuff.
Yes.
Like they will avoid meals.
Yes.
They'll say, I have too much work, I can't come when everyone else is dining.
Yeah.
They will they'll be picky eaters. So this was always one which you worried about with our kids, right? That some kids are picky eaters by nature, right? But at what point does it become pathologic? And what you're saying to me is when you're actually seeing them lose weight.
Yes. Or in children not developmentally appropriate gaining of weight.
Got it. And that was a huge part of your practice because you your focus was on adolescents and children, which is a very, very challenging type of psychiatry because you can't just ask them.
But rewarding as well.
100%. But I would say versus the older set where you can actually ask them what's on your mind, with a kid, you can't always do that.
No.
And so you're just watching for cues.
Yes.
Okay, so someone has anorexia nervosa. My understanding, and you will educate me on this, it's probably the worst of the different maladies in terms of prognosis.
Yes.
So how does that play out? The second thing is, now we've identified what they are. How do you diagnose them?
So the first question, early intervention. The earlier you intervene, the better is the prognosis. So if you're worried about your child or, as an adult for a friend, just refer them, get them to a doctor. So because the later you leave it, the more rigid the patterns become. So they're that much more difficult to turn around.
And what do you use for that? I know you treat some of it like an OCD, where you'll use medications and SSRIs and depression and things like that. All of these terms you don't need to know, but the point is the psychiatrist needs to assess them. They need to do the assays, as I recall. How do you diagnose it?
So one is the clinical diagnosis. So we take, being a child and adolescent psychiatrist, I speak a lot to, the parents, observe their behavior, and it's mainly the clinical interview. We spend a lot of time, about an hour with the parents and the child. And then there is the screening questionnaire. So you also do the eating attitudes test, the shorter version or the longer version, to get a formal diagnosis.
And we'll put a link in the description on that if you guys want to learn about that.
Yeah. So that's how we get to a proper diagnosis.
And so now you've diagnosed someone with anorexia nervosa or bulimia nervosa or with other forms of eating disorders. What's the next step on the pathway? How do you manage this?
So a lot of psychoeducation, because as I said, first the parents are in denial. The client definitely is in denial. They just don't think they have a problem. So a lot of, sharing information, getting them to acknowledge that there is a problem, getting them to come to a point where they're willing to take help, because they are a lot more resistant than the usual ones to treat. So psychoeducation, one-to-one counseling, we do a lot of CBT, we do family therapy.
CBT, what is that?
So cognitive behavior therapy, that is a one-on-one with the child, depending on.
So you kind of reinforce certain behaviors, defeat other behaviors,
yes.
and
change the thinking, the way they think and the way they look at things.
Yeah.
So that a lot of family therapy. Family therapy is one more thing that doesn't get as much acknowledgement that it needs to in India, because as we know,
India, the world, right? I mean, you have so many dysfunctional families, and the bottom line is, it would be good if they could talk with a professional and kind of diffuse some of the issues which are buzz items rather than letting them get farther. So that's another topic for another day.
Yeah.
But what is the role of medication in these patients?
So it depends on for anorexia, we have to be very careful what body weight they are, because some of these medications, if they're at a really unhealthy, like a 14 or a 15 BMI, if you treat them, they could cause, fractures, and because of the bone density. So we need to be very careful what we are treating and why we are treating it. Mainly we are treating the rigid thinking, and, secondary, there are a lot of psychiatric comorbidities associated with anorexia. So there's a lot of depression. We've already spoken about OCD. There is body image issues, there's anxiety, and drugs and alcohol. There are a lot of people who are using drugs and alcohol to cope with what is going on.
So this is great that there's two things. One is in the diagnosis, using some sort of more granular and objective criteria to say someone is underweight. So in kids you can use a height weight chart. In adults it's not as easy, and oftentimes what I was reading is that they'll wear baggy clothes, or they'll wear dark clothes, or they'll figure out so no one can see that they've lost weight. Right? So that's in the extreme part. The second thing is BMI is not as good indicator because it's a body mass index that looks at height in meters squared over kilograms, right? And so the problem is that depending on how people are structured, it may or may not do it.
And sometimes they might be at a healthy BMI, but it's also the rate of loss of
100%.
weight.
100%.
So if they've lost a lot of weight, someone who was overweight and suddenly lost weight, come to a healthy weight, people think they're healthy, but no, it's also the rate of loss
Now,
of
the
weight.
other thing I had read in women, they'll actually stop their menses. And that's because they don't have enough fat in their diets to create the hormones, estrogen and whatnot, to maintain the cycles.
That's interesting, because we had amenorrhea as part of the DSM, criteria, and that has changed. And that, I think, is also why it's changed, is now we are seeing more males as well having body image issues. So, it's no longer an essential criteria, that amenorrhea. So, the thinking about eating disorders is changing, that it's a culture bound and female bound syndrome. So now it's universal.
This is an interesting point. The other interesting point is there ever a role to inpatient therapy?
Absolutely.
So when do you admit someone, and what is the criteria in India? Because I know in the US you could put them on a 72-hour hold if you thought they were a risk to themselves or someone else. But beyond that, the hard part is to get them to recognize. And most of the time we would see patients like this, it would be their parents or loved ones would bring them in. They wouldn't always recognize that they had a problem because they were going through it. And then when that happened, like in my friend's case, they had to admit their daughter, and for all of us, we were on pins and needles because we didn't know what would happen. And thankfully she's come out of it and she's doing okay, but it's always looming. It's always something we worry about because the recidivism, meaning it coming back, is significant in a lifetime in the worst of cases. So what do you do when you admit them, and how do you treat this?
I think one of the challenges is that we don't have a specialized, eating disorders unit
in India.
In India,
So this is an action point for everyone out there.
So unfortunately, I had to admit adult client, young adult, and all they did was tell them to eat, which is not, so there is a structured program. So when I was working in the NHS in the UK, it was like, a certain BMI, you have to forcefully feed them. So you have, the nasogastric feeding.
Wow.
Especially if you know that they are at a lethally low weight and they're refusing to eat. So there's IV fluids, there's, that's all that you concentrate on, is getting them hemodynamically stable. And once they're there, then you start working with them. So
So they don't even have a chance at that point because clinically, mentally, they're not capable of taking care of themselves. And you're really just
rigid.
going...
there's no point telling them to eat. They're not going to eat, or to do, the CBT that we were talking about.
Fair enough. And so what is the prognosis? I mean, when you talk to a patient's family, I would say in a normal eating disorder with just bulimia or some of these other things, is the prognosis as bad as anorexia?
No, it's much better because it's more emotional than, body image and the rigidity of thinking. So working with the emotional aspect of binge eating and bulimia is much better in terms of prognosis. Anorexia, a little bit, not that it's a bit lean, a bit meek, but it's not all doom and gloom. So, about 50 to 70% of people have a, good recovery without having to relapse into the pattern again.
So, I was looking at risk factors for this, and there is a concordance in eating disorders hereditary or genetically, right? Which I found fascinating that we've never identified a gene for this or any type of protein which gives you this. Maybe it's for psychiatric disease in general and neurologic disease in general.
Yes.
Are you finding that, and the question is it nature or nurture, which will kind of bring us to the next topic, that society and culture in India as well as globally has turned. So let's talk about the genetics first.
Yeah.
Are you seeing a genetic component to this? That if a family member had it, it's likely the kid or any of the other family members could have it. The second thing is it that clear that is it a true genetic thing or is it something on the nurture side where culturally they behaved a certain way that you should not eat this, this, and this in the family, which oftentimes in our culture we do that, right? So what is your thought on that?
So interestingly, I'm seeing genetics in terms of, parents having a bit of it and then it getting exacerbated in the next generation to a diagnosable condition. And there is a lot of, nurture, nature, that kind of a thing where there are certain patterns that are followed in the family. I'm seeing young children now, in school going children, in parents group discussions about why are they serving chocolate? Why are they serving sweets in school? So I think people have got a lot more aware and they're, trying to portray all of that into their children. So I have seen kids who think chocolate is poison.
Wow. That's interesting.
Yeah, it's like, I'm not allowed chocolate because it's not.
But this is an interesting discussion because in our house, for obvious reasons, we're in front of cameras a lot, right? But at the same time, we're total foodies. And so it's the angel and the devil effect. But the interesting part is my wife and I have this discussion about the fact that kids should be able to eat cookies when they're kids, because when you get older, you can't just do that. And my only argument with that is I would say teach them healthy eating habits and teach them that happiness is what's important and how you look is not, it's how you feel, right?
Absolutely. I would go with, I think Madhuri's side that, they should be able to eat chocolate.
So I don't have a problem with that. It's just that if that becomes their go-to snack, like cookies and chocolate and all that, because, let's call it that when you're hungry, you reach for the most prevalent thing, right? Yeah. And if that's chocolate and cookies and things like that, the quick high that you get from those chocolates and cookies is total satisfaction. And I'm the first to tell you that I've been there. But the flip side of it is what you pay for with that. Whereas if you, basically were on fruits and on healthy stuff, which was equally there, and you sort of disciplined yourself and because a lot of it is habit formation, right? Yeah. But it's a very slippery slope.
It's a very slippery slope, and I think my advice would be anything in moderation.
Okay, I think that's fair.
Because it's almost like if you tell kids that you cannot have fries when they're really little, they're going to bound to, have that rebound. Whenever they're out, they're going to gorge on it. Yeah. So I think
let them try it at home.
Let them try a little bit of at home. As I said, don't say.
But also educate them on the risks, right?
Absolutely. And once in a while, not every day, but once in a while, as we are saying, cheat days, let them have a little bit of everything.
I think that's very fair. Yeah. Now let's turn the page a little bit. You've got this huge social media movement. And you also have this size 0, which was coined probably in India and other places. How is that bearing relevance on this? And how do we combat that? Because, I struggle with this, and they have these very amazing filters, and there's this whole movement in the pandemic with Zoom and the filters you put on.
Absolutely.
And with Instagram. I'm sure you guys out there understand. where you make people look different.
Yes.
And so I would say that also pushes the envelope on this. And for the people who are vulnerable, puts them into a situation. And it would be an interesting kind of thing to study, that if you were to take 100 people and put them in that same situation, how many of these people would end up with an eating disorder?
Yes.
So how do we look at that? What's your experience with this?
I think you rightly hit the nail in terms of vulnerability. So people who are seeking external validation are the ones who are going to get sucked into it. People who have a happy home where they're getting validation from their parents, from their relatives, from the extended family, who believe that they're beautiful, are no longer going to find that from external sources. So I think social media, yes, peer pressure, huge issue, but yeah, as I was saying, there's no escape from social media. People who are a little bit on the chubby side are getting fat shamed constantly, and they're believing themselves to be ugly, and that's the problem, where they're seeing other people, comparing themselves to other children, younger people, want to be the size 0, and sometimes you can't, it's your inbuilt, the way you're built, the genetics, all of that. So you need to accept, so long as you're healthy and you're happy, that's completely fine.
And so that, I think, is the thing that I would say, that we've always promoted on the channel, that everyone is beautiful and no one comes in one shape, size, or color, or background. And what we need to do is embrace that and say all of us are beautiful together. The second thing is, everyone has superpower. You just have to figure out what it is. Because the problem is that if you neglect that part of your fundamental makeup and look for external gratification, and I've talked about this on the channel before, about the article out of Harvard which looked at extrinsic versus intrinsic motivation, and how everyone wants that Instagrammable vacation, or the picture with certain clothes, this, that, and the other. They should be going after is the intrinsic motivation and the happiness in the family unit. So I think the other take home from what you're telling us is, we need to be a mutual admiration society.
Absolutely. Tell your kids they're beautiful every day. I do that.
Yeah.
Because they need to believe they are.
But do they ever say, Dad or Mom?
I still continue saying it.
Yeah, I know. So I've been there. And so, I mean, that's the challenge. And then with adults, I think, we need to stop saying, I can tell you from my background and yours, when you walk into any Indian household, someone will make a comment about something.
Yes.
And I've told my mom and dad, I'm like, look, don't comment to moti jali, to choti jali, heta. Not important. I'm here and I'm there for you. And what we need to do is get away from that cultural adjunct. I know they're trying to show love by saying, I notice you, I see you. But they'll see you either way, and they want to be with you. And so we need to kind of re-educate and reculturalize some of this.
Absolutely. I think we don't ask kids how they are. You comment on external appearances, and we need to rightfully move away from that. It's about, hey, how you feeling? How you been? How your week been? Has there been anything that upset you? But yeah, that needs to be the normal conversation.
And so in summary, eating disorders is here and being recognized. I think until recently in India, we didn't recognize it. It's not a brown person's disease. It's a white person's disease, quote unquote. I think it's clearly in the metros, 2nd, 3rd, 4th tier, and it might be hidden, but it's something which we need to really recognize is real.
Yes.
The second thing is, stop judging and start loving the people for what they are, because the bottom line is, you'll find their strengths are much beyond how they look.
Absolutely, absolutely.
Yeah, and so now the question, and everyone's going to say this, Doc, your wife's in the industry and all the other stuff. How is it and how would it work if you weren't, looking like you were? And this is always one of those difficult ones that we struggle with.
Yeah.
But I think some of that has changed with OTT. You've seen characters coming out.
Yeah.
You've seen them casting people. And I'm not talking about our case, we're talking about in general. That it's about having fun, and it's about telling stories that people need to do. And maybe that's what we need to embrace, that it's the story.
Yeah.
It's not the book that it comes in or the cover that you're judging, as they say.
Yeah, absolutely. I agree completely.
Any last words on this? Have we pretty much covered anything? Is there anything more you want to say to the audience in terms of, I'll tell you, we'll talk about it as another episode. I think in India, we don't have good enough psychiatric and psychological mechanisms in place to take care of people who are underserved. We're going to talk about a lot of different topics: depression, suicide, anxiety, all of these things together. And I just think there's an opportunity here. But the first step in this journey is to recognize.
Absolutely. And raise awareness about it.
Yes. And so that was the point today. And thank you so much for joining us.
No, thank you. Thank you for having me.
And so, as always, you guys, and I'm going to say this at the start, and we'll do a little thing which we'll put in. If you want to see more episodes like this, hit the like button and the subscribe button, and always share this with your friends. Things like this are fundamental to the structure and values of our society, and the only way we're going to spread them is together. So thank you for joining us. As always, it's been a pleasure, and I look forward to seeing you in the next episode.